Hello, everyone. This is County Council Member Deni Taveras, and I am the Vice Chair of the County Council here in Prince George's County. It's been an honor and a pleasure to be with you here today. We have been, this is the month of May, and we've been celebrating Mental Health Awareness Month all the month of May. And we, in the spirit of that, we've had a series of mental health panels, and this today is our last one. Last week, we held a mental health panel on children, one on seniors, and today earlier today, we had one on women of color. And right now, this is our Men of Color panel. These have been amazingly informative panels. I highly encourage everyone to review the videos that will be available online and through my listserv. And so I welcome you all. Hopefully this will be a really engaging experience and a wealth of knowledge for us all. Hola, soy la concejal Deni Taveras. Soy la vicepresidenta del Consejo de Prince George's County y este es el mes de concientización acerca de la salud mental. Y en ese espíritu nosotros hemos tenido varios talleres acerca de la salud mental, acerca de los niños, gente en tercera edad, mujeres de color, y ahora el panel acerca de hombres de color. Si necesita traducción, por favor, llegue a su pantalla, verá un glóbulo abajo que dice interpretación y escoja su lenguaje preferido. Y la señora Miriam Lev estará aquí para traducirle a su gusto. Muchas gracias y por estar aquí con nosotros hoy. Just as a quick reminder, this is a bilingual and simultaneously translated event. Should you need translation, please press the screen and look below to the globe that says interpretation and use your preferred language. Select your preferred language, and I hope that this will be an engaging discussion. So with that, I would like to open up our wonderful, illustrious panel. We are missing one individual, but I think these gentlemen will be more than outstanding. We have the Honorable Council Member Charles Wiley. Would you like to speak and kick us off and tell us a little bit about yourself and why you're here today?
Thank you for having me. My name is Charles Wiley. Currently, I'm serving my third term as council member of the town of North Brentwood. I also work for the past 15 years. I've worked as a behavioral specialist in a non-public day school setting. So mental health is something that I've learned and want to take advantage of and kind of get the information out to the community. Since I've gone back to school to acquire my degree in psychology, trying to be an asset to the community. So that's me. Thank you for having me, and I'm honored to be here.
And now we have I know that there's the level of competition on which HU, but I'm sure it's the correct HU. Dr. Marcus Hughes, would you like to introduce yourself?
Sure. Hello, everyone. There is only one HU. Let me just say that. Yeah, so I'm originally from New Jersey. I went to medical school in New Jersey at Rutgers, go RU. I am a PGY1 resident within the Department of Psychiatry and Behavioral Sciences at Howard University Hospital. I am particularly interested in promoting health equity within the field of psychiatry. and eliminating and alleviating disparities that we may see as a result of race and discrimination within the healthcare system as a whole, but specifically within the field of mental health. So happy to be here.
It's a pleasure to have you, Dr. Hughes. And now we have our own very own Dr. Zebro. I thank you for coming here today and being with us. Would you like to introduce yourself?
Thank you. Good afternoon, everybody. My name is Dr. Zebro. I am originally from Africa, Ethiopia. So I immigrated here 20 years ago. I graduated from the medical school in Ethiopia, and I did my residency in the University of Virginia in a combined internal medicine and psychiatry. But even prior to coming in here, back in Ethiopia, I was practicing in psychiatry. Why? Because mental health is the most stigmatized, the most neglected, and really the most underserved, field of medicine. And so here in the United States, in addition to psychiatry and internal medicine, I specialized in addiction medicine, where I'm right now working as a director of Pathway with the Luminis Health in Annapolis, Maryland. So I believe that we need to look into people in a whole, meaning just general health, mental health, substance, all are interrelated, and all of them are disproportionately provided in a very limited manner to people of color in general, or minority population. So this seminar, this webinar really fits into my philosophy of providing care, making care accessible, resources accessible, service accessible to the most vulnerable, the most underserved population, the most needy of the population of this nation and globally, as a matter of fact. Thank you for having me.
Well, Dr. Zebro, thank you so much for that opening. I think that we will be touching on a lot of what you said, because I think it's so relevant and so significant to the needs of our community, given a high percentage of immigrants. Let's kick it off on the easy level. What is mental health and why is it important? Why should we care about this topic in the community, specifically to this particular population of men of color? And it's open. This is a question open to all of you.
Okay, well, I guess I'll start. Mental health it's really hard to kind of define it. So I really looked it up, to be honest. And it's according to the definition, it's having my uncle used to tell me all the time, make sure you have your wits about you. So when you have to deal with situations, you're able to think through it and process it appropriately. And mental health to me is the ability to process through those difficult decisions that we have to make, whether it's somebody pissing you off, whether it's somebody making you happy, trying to appropriately respond to those situations. And it's important because we see the effects on the news every day. The things that are happening in our communities with our youth, with, you know, all of the travesties. So it's definitely really important.
Dr. Hughes, you want to?
Yeah, sure. So I agree with what the councilman said. You know, for myself, you know, I also, you know, was trying to define this in my own way, and was like, I think I just need to look up a definition, because it's such a vague concept. It's a concept that we use all the time, and you know, I didn't want to be too superfluous in terms of talking about what it is. So, the definition I found is mental health would be an overall state or condition of your emotional, psychological well-being, including your behavior and your cognition. So that will also represent, you know, the way you think, the way you concentrate, your level of attention, how you learn, how you remember things. You know, in terms of your mental health, having good mental health, you'll be able to manage all of those things appropriately. Relevant to our communities, you know, like the councilman said, especially in these days, we're seeing, you know, we're seeing more and more the assault that's going on towards our communities as Black individuals, and having optimal mental health, being able to process these things, being able to understand your emotions, knowing where and when to go, you know, to process these things, will allow us as a people, as a community, to move forward and move past these things and hope for, you know, a better future for ourselves. So it's quite important for that reason to make sure that you're okay. And like the councilman said, you have your wits about you, so that we can get through this period and any period we might see as an individual or as a people or as a community.
Yeah, so when, where, and how, right? How to go about doing that. So Dr. Zebro, you have a special definition you like to?
I agree with, you know, both, you know, definition, but basically mental health is just it. It is just the thing. So if a person, you know, mental health is not right, you know, everything is just secondary. So the mental health is just primary. The rest of, you know, the thing, whether it is heart problem, diabetes, you know, you name it, it is just secondary. If a person has a mental illness, it is, you know, as we know, it's very difficult to attend to anything. The basic things, like kids with autism, with intellectual disability, you know, we know, you know, they cannot take care of, you know, the basic things. Adults, the same thing, you know, elderly people with a neurocognitive disorder like dementia, then, you know, they're unable to do their basic, you know, ADL, activity of daily living. So mental health is just primary. It is just really the core. If we have to take, you know, health in general, mental health is primary. Let alone, you know, just, you know, others like, you know, this frustration, you know, depression, and, you know, just not feeling well, you know, these are very important things. But you know, what we are seeing in the society is significant impact, significant impairment of mental health, which is really, you know, affecting, you know, across the board. So mental health is just, being mentally healthy is everything, and not being mentally healthy means losing or not having anything, pretty much.
So you're getting a little bit ahead, because I was just going to hit on that. Where, like, what are the types of mental health illnesses that we see more prone to suffer within men of color, and what are the risk factors? Like, who is at risk and what are the risk factors? So I know you mentioned depression, Dr. Zebro, but and I believe you mentioned anxiety and other. But what are some of these other things? And again, who who is at risk and what are the risk factors that triggers that? Do Charles and Dr. Hughes and Dr. Z, do you want to chime in on that?
I just want to be careful of using the language at risk, because when we start speaking like that, we scare people, and mental health and illness is not scary. It's one thing we've been taught in our community, that that's why it's so ostracized and hidden, because it's presented as scary. So I just want to be careful with using the who's at risk, or, because that really changes the dynamic when people feel comfortable about speaking, because I don't want to be at risk. You know what I mean? So just to kind of speak on the language part of it. And I'm not sure. Me personally, I believe everyone is at risk for everything. I think there are more people with mental disabilities than there aren't. It's just that they aren't diagnosed. A lot of the things and the behaviors that I had when I was growing up are now being diagnosed and given labels. So and it's expanding every day with different diagnoses, and it's neurodiversity, and there's so many. It's expanding every day. So I just want to kind of just put that out there.
So what are warning signs, or how is mental health or mental health illnesses masked?
So I'm sorry. I just wanted to touch on the previous question. So just in general, I believe most mental health conditions occur at similar rates across across the races in terms of white and black. But I think the councilman hit on a important point when he said a lot of the behaviors and things he was doing when he was young are now being diagnosed as things. And within this country, when you talk about this country and the history of this country, you have to talk about the history of racism, the history of discrimination. And that is prevalent even within diagnostic criteria for certain disorders, whereby historically certain behaviors and behavioral patterns that are normal or normative to certain cultures, like the Black cultures, Black communities, might seem abnormal to the majority of the population, which would be white people. So when the white people are making the diagnostic criteria for things and they're determining what's normal and what's not, somewhere along the lines, behaviors that might be normal to us will become what we call pathologized and will be, given these diagnoses. And historically, one of those things is schizophrenia. Schizophrenia has a prevalence of about 1% throughout the world, but for some reason within America, schizophrenia is diagnosed at rates of 3 to 4 times as high in Black people than white people. Why is that?
Really?
Yes. So you have to look back historically and say, in the civil rights movement, that era, they pathologized a lot of that behavior and deemed people mentally ill. And thus those people were taken out of the streets, out of circles of activism where they weren't able to enact change, and placed in institutions such as mental hospitals or jails. So historically, there are ways where behaviors that we think are normal or integral to us and our identities, they become pathologized by the greater, diagnostic community, who happens to consist largely of white people. But to speak to the question, most psychopathologies, most mental health conditions occur at about the same rate in white people and Black people in general.
That's fascinating. I feel like calling you Dr. Z. Dr. Zebro, do you want to speak to that? And I would say particularly from the aspect of what are we seeing amongst our men from immigrant backgrounds, and because I think that given the high population of immigrants here in this area, at least in District 2, I think that these are real issues that we're seeing and how they mask or present themselves.
So in general, the approach for mental health, as far as, the cause or the risk factors, they're classified in 4 categories. One is a predisposing factor. What is predisposing people to mental health? That is mainly genetically predisposition. So, mental illness runs in the family. Then comes the precipitating factor. What is precipitating? People were doing well, all of a sudden, they develop something. So that could be, it could be related to loss, parental loss. Somebody get killed, somebody becoming sick, or somebody being put in a foster home, or somebody being assaulted. So any number of precipitating factor, financial losses, losing job, losing health. So these are precipitating factors. So the third P, we call them 4 Ps. The third P is perpetuating factors. The perpetuating factors are if a person is struggling to get out of a situation, but if it keeps hitting him again and again, like for instance, a person, for instance, a person has DUI, he's put in jail. When he comes out, he lost his job. Then, loss of livelihood, then putting him on certain situation. Then the cycle continues. Or a person is in a marital situation where the marriage is kind of abusive. So that abuse is ongoing. So it is a perpetuating factor. So that person cannot get out of the situation. So is predisposed to develop a certain condition like PTSD, depression, anxiety, and others, or drinking to deal with the stress and frustration. Then the 4th P is the protecting factor. Protecting factors are the positive things. What are protecting the community or family or individual from mental illness? These are good health, family, having children, having supportive community, or not being in for instance, in drugs, good academic, achievement, or good academic, graduating from college, having a good job, having a good prospect and development, spiritual life, and good role model in the community. So these are protective factors. So we see mental illness or predisposition or risk factor for mental illness on those 4 factors: predisposing factor, precipitating factor, perpetuating factor, and protecting factor. So the presence of 1 or 2 or 3 in the absence of the 4th one, the protecting factor, is predisposing our community to mental illness.
And I think that that's really important. I think that highlighting that these things can mask, as you said, in the perpetuating factors, that it could be masked with alcohol or drugs or, abuse and those kinds of things. I think that those are really key things. And we'll talk about that, I think, a little bit more in depth. in the worst case scenario, what does depression look like in men of color? I mean, based on your experience, is there a range or is there a, you know, well, what do we see? What are you seeing in your experience?
I don't even think we can qualify that. Go ahead, Doctor.
Dr. Hughes?
Sure. So I had just one more comment to make about the previous question in terms of risk factors. Something that's, very important to our community as Black people, something that was very evident within the body of literature that's on this subject, is that while, like I said, Black people might not experience depression or depressive states at a higher rate than white people, some studies even say it's slightly lower. But when they do experience depressive episodes, when we do, those episodes persist for longer, they're more debilitating, and they're more resistant to treatment. And you have to ask yourself why that is. Other data shows that, Black people utilize resources and services at a rate of about 50% less than white people. And you have to ask yourself why that is. If someone is feeling down, why would they not reach out to services? So then you have to start to think about access to these services.
Wow.
And you have to start thinking about how the percent of population, like Dr. Zebro said, of Black individuals in the foster care system, the percentage of Black individuals within the prison industrial complex, the percentage of Black individuals in the homeless population, and the population of individuals that are below the poverty line. Most of those domains have a majority of those populations of Black people. You think about the historical mistrust of Black people towards the healthcare system. You think of the fact that, at least speaking about psychiatry and psychology, 2% of psychiatrists are Black in this country. 2% of psychologists are Black in this country. About 4 or 5% of social workers are Black in this country. So for individuals that even do make it to the point where they reach out to find a provider, what is the likelihood that that provider will be able to be, culturally relate to them, understand them fully, have the adequate level of empathy that's necessary to treat someone that's going through something that may be culturally related. So all of these things I think need to be taken into account. And, also, decreased exposure to educational opportunities, employment opportunities, availability of insurance, historical redlining, Jim Crow law. You can go on and on about how disadvantaged Black people are, and then you can see how that can relate into the decreased utilization of resources and services that might be available for everyone, but might not be accessible by certain people, disproportionately Black people. So I think you have to consider those things when you think about what risk factors people have for certain psychopathologies. You have to.
I mean, you hit it on the head. I mean, and these statistics are so significant. And I think that they were so key to share. So I thank you for that. And even talking about that, I was just, we were just talking about that in the previous panel. I mean, in so many ways, in the sense that we were talking about the strength of, I think that when we talk about the fact that there is a third less likelihood of folks not not having serious mental health issues, a lot of that is also very much, some people may say maybe rooted in the church, right? Because they feel a very strong sense of affiliation within the church that addresses a lot of these emotional support needs and having that community of support around individuals. The thing is that sometimes when you do have individuals that have greater needs, you can't always pray it away. Yes, you can go to your pastor but you also want to go to a health professional, because a pastor, in some cases, they may be well aware, they may be prepared, but in some cases they may not be able or capable to handle some of the more sensitive mental health issues. And therefore, the church would always need to have a set of resources available to them so that they could refer their congregants to some of these locations where there is professional services provided. In the same way you deal with diabetes and heart disease and some of these other things, you should be able to address some of these mental health concerns. And then looking at the fact that you're right, that there aren't enough people of color in these industries of social work and psychiatry. I mean, they're just not enough to go around. And I know we were just highlighting that in the RAND report here in this county of Prince George's. I mean, I think it was like one for every 2,000 people, we may have a gap. And I think that's more stark than the therapist, but even, it's significant still, of several hundred, one per several hundred individuals. So we're talking about some significant numbers in the fact that we do not have enough people. And I was saying, as for full disclosure for myself, as somebody who, I lost my mother to suicide, I lost another family member to suicide. So these are things, and I have family members who have been diagnosed as schizophrenic and so on. So these are real realities that even with the fact that I'm well educated and whatnot, I didn't know that I had to take care of myself as well. And so when it came a point where I had to go see someone, I didn't understand what that was until somebody pointed it out to me, despite the fact that I had several degrees under my belt already. And so, and when I said, and then I was saying at the other panel, it's like, okay, well, when I wanted to come across when I wanted to sit down with somebody, I wanted to make sure that that person was of color. And I wanted to make sure that that person understood Dominican crazy. So those are real specific issues. You want to have the person understands Ethiopian crazy, Eritrean crazy. Everybody wants to know, you want somebody to understand you're crazy. And so that to me was real important, that, that you want to have that, what we code to have culturally sensitive individual that understands the language that we speak and the cultural context with which we're coming from. And so that, and when you highlight this issue, Dr. Hughes, with regards to all these compounding realities that we face in this country with regards to the lack of educational opportunities, systemic racism, the school to prison pipeline, the whole cadre of baggage that we bring as people of color. And I think it's also very special, the African-American experience from, let's say, other communities of color, let's say like Africans and Caribbeans like myself, who we come from countries where everyone is of color. So there's a different sense of empowerment that where we come to the table with a different sense of empowerment than the African-American experience. And so I think that we have to be, as people of color, we have to be sensitive to that. I mean, it's not always perfect, because even in Brazil, or the Dominican Republic, or Cuba, or wherever, we still have similar issues, right? Because African-Americans here are by far the wealthiest across the world when we look at it. So there have been serious advances, but there is still a sense of challenge and national that comes with that I think we also need to be sensitive to. But but when we And I don't know if we already touched on this. When these things go undiagnosed and untreated, how do these things manifest, right, themselves, not just in the individual, but also in our communities? Let's get real about this. I think we need to touch on this. Mr. Wiley, do you want to tackle and kick us off on that?
Hey, it's going to be different. It's going to manifest itself differently for everyone. But I think I'll speak for me personally. When I get into that state of depression, it affects my family, like my daughters can tell. It affects my job. It affects the way I interact with people. So it affects every aspect of my life. But it's funny because I've always been raised to just deal with it. Doesn't matter how bad I feel, I have to make sure everybody else is okay. And part of what we were talking about earlier, like as a man, as a Black man, as a man of color, a lot of times there's a hopelessness feeling that no matter how hard I try, how many accomplishments I get, or how decorated I am, I'm still not going to be the same. So having to live with that every day and having to deal with that as trying to stay mentally healthy, who can really help with that? Like you said, there's 2% of the population that are psychologists or psychiatrists, somebody who can relate to me culturally. 2% is not enough to help the population. So, yeah.
So I just want to make a note that Mr. Ken Alford is here with us. Thank you for joining us. Dr. Hughes, do you want to tackle that?
The impact you were saying of?
Yes.
Yeah, so I mean, I think like the councilman said, it's pretty much a case by case basis. It depends on the pathology. I mean, so for instance, for us as psychiatrists, we use a book called the DSM-5 to make diagnoses, correct? Within that book, there's over 150 different psychopathologies. So depending on the individual psychopathology, the mental illness the person has, it might determine the impact that they have on people around them. It depends on the people around them, how sensitive they are to that psychopathology or their disposition towards that. So I think it's always a case by case basis, but like the councilman did say, in general, when people have, let's say again, depression, it can certainly affect, the way that you interact. You might feel like you have less of a meaningful interaction with that individual because of the fact that they might be withdrawn, or they might not be as interested in doing things as they used to be interested in. Maybe you don't see them as often, or when you do see them, like I said, the interactions you have are less meaningful, and that could have an impact on you. It's a case of schizophrenia or, maybe a primary psychotic disorder. If that is untreated, that can lead to significant distress for the people around you. There could be increased violence. There could be, you worrying about whether or not the person might, manifest a delusion or hallucination that might put them at risk. So, it depends on the psychopathology, but I think, within the world of, mental health illnesses, when we talk about a disorder, it is implied that you have some impairment in your functioning, like the councilman said, that might manifest in your work life, your interpersonal life. You might not be able to take care of yourself in the same way. And all of those things, how they uniquely manifest for that individual, will affect the individuals around them in a unique way as well. So it's a difficult question to answer fully, but I did my best. So.
And I don't know if you, one of the common threads that had been through some of the previous panels was the presence of PTSD in our folk. Dr. Zebro and Mr. Alford, do you want to speak to those issues or the presence of that in conjunction to what we just finished discussing?
So I agree with Dr. Hughes and Councilman Wiley with the mental illness, particularly depression, manifest in a different way in a different individual depending on their adaptive capacity and presence of protecting factor. But what we see as clinician is just the tip of the iceberg. Majority of people with depression, we never know about it. Sometimes they don't know about it. They know that there is something wrong, things are not going right, and there is a term what we call health literacy, being aware of our health, including our mental health. So how much is our community aware of our mental health? So as Councilman says, most people have to deal with it because it's not something you want to share with somebody else or you wanted to seek help for it. But when it comes to the level, when it is getting really worse and worse, when it comes to the level of requiring care, it is usually it's gone too far. Meaning the most common mental illness leading to suicide is just depression. So that is either people attempted or already successful with suicide because of untreated depression. That is one aspect. The other aspect is.
Can you talk about some of those specifics on like what are the risk factors, not risk factors, but some of the suicide, some of the flags? We have people now that are on the front lines of this, like Taraji Henson talking about these issues. And I mean, we know so many key people, who've lost children and sons. I mean, when we're talking about the age group of African Americans between the age of 18 and 24, they are a risk group of higher increase of precedence of suicidal ideation. So can you talk a little bit about what that looks like?
So there is no really a litmus paper to know, to identify this, risk factor, but any change from their baseline, functioning, like not talking, isolating, not performing at school, dropping grades, or failing grades, getting in trouble with the law, start using drugs. These are really the signs, the warning signs. Something is going wrong. What is going on in that young man's life? Yeah. So why is he not with his friends? Why is he not talking at home? Why is he not sitting with the family and eating? Why is he just in his room, just in the dark, just brooding? And the physical appearance, moms usually they notice, just by the look of their children, that there is something wrong. What's going on? What happened?
Not showering, not taking their physical
Yes. So that is one part. The other part is the you mentioned PTSD. So PTSD it arises either by witnessing or by being part of a violence, any kind of violence, by hearing about it, by seeing it, witnessing it, or by this violence happening to that person, to self. It could be combat related, it could be, sexual abuse, sexual, assault. It could be witnessing people get killed or shot at. or stabbed or armed robbery or any kind of violence. So it is very, very common. It's very, very common. We hear about it, and we see sometimes, every day, depending on the degree. That is one aspect. Then there is another aspect. People of color, they participate in, the national defense. We see people coming from, Afghanistan, coming from Iraq, coming from, combat-related, deployment. We see a lot of PTSD. So PTSD, combat-related PTSD, and combat-related PTSD happening in the house, being in relationship, abusive relationship, seeing it in the street, in the neighborhood, everywhere. So,
so we're almost reaching, Dr. Z, we're almost reaching to our end. I just want to bring in Director Alford. Taking a systems perspective, what do you see are some of the key behavioral health assets in the county? And what are the areas of improvement that you see?
Okay, thank you.
Introduce yourself while you're
I apologize. Thank you. Yes, my name is Ken Alford. I'm the Systems Director of Behavioral Health for Prince George's County, University of Maryland Capital Region. Our hospital system, we see inpatient behavioral health individuals when they are at their worst. Usually they are either a danger to themselves or others. They have been brought in by police commitment, and we are the team of clinicians that are in charge of stabilizing them, supporting them, and transitioning them back to the community. Our impact, unfortunately, usually when they reach us, it has been, it's at the worst. So that's what my team does. And to answer your question, when I look at this at the—
When you say at your worst, are we talking just strictly mental health, or a combination of health and issues of alcohol and drug abuse, or what are we talking about here? Or just, or is there an intersectionality with crime and the justice system,
Yeah, all those factors you mentioned are at play. When I say at their worst, these individuals usually at the point that they have attempted to harm themselves, they've attempted to harm others. They usually are with co-occurring disorders like alcohol, drug abuse. We see an enormous wave of PCP use in the DMV area. And honestly, we could do a separate panel just on that because we don't get a lot of talk about the horrific effects that PCP is having on our African-American community. But when they come to us, everything that we've mentioned with the PTSD and the depression, it all comes to stop because now there's no place else to go and they're truly at their worst level of functioning. So our job, unfortunately, is to try to stabilize that in 5 to 6 days, which is really impossible. All we can really do is put a Band-Aid on and hope we can connect them to services that they will connect to start the healing. So to answer your question, I see this in 2 ways. We have this cultural dysthymia and cultural PTSD. Our urban communities, homelessness, lack of resources, police brutality, you could name various factors that contribute to people's mental demise. And then as they continue that downslope, eventually the depression, which is a long-term kind of the depression, very chronic, impaired relationships, inability to really get up, hopelessness, not seeing a way out, and then using drugs or other substances to kind of cope. All those things really intersect and causes continued mental health deterioration. So unfortunately, until we get to the root of the kind of the social issues, these factors that cause the trauma will continue to occur, and the depression and some of the deterioration of I mentioned already as we continue to try to help our community heal.
So as I was mentioning in the previous panel, I felt we're going to go a little bit beyond 1 o'clock because I think that I want to squeeze in a little bit more. And I don't know, I feel strongly that we may need to redo or expand this panel, because this panel is, compared to some of the other panels, this is just so much more important and so relevant to the things that are happening in this day and age. I mean, not to say that other issues aren't as equally important, but I find that this is a particular issue that we need to hone in real deep. One of the things that I was saying was that I didn't realize when I felt I needed to get mental health services, and what I found, and I came into that very late in life, despite the fact that I had several losses of my family to suicide, et cetera. And the realities of mental illness within my family and the predisposition that we have to that. But once I got the help, and once I was able to do what I was supposed to do to improve my mental health being, my outcomes changed dramatically. I mean, it's like night and day. I mean, we're talking about changing in income opportunities, changing in career advancements, changing in, shoot, I got busy. I mean, things different. I mean, everything got different, you know? So I'm just saying that, like, I can never stress enough the importance. But the thing is that the key issue for me was finding individuals that I connected with, that I clicked with, that I felt I jived with, that were culturally competent to address my needs. And as Dr. Hughes mentioned, there is such a scarcity of that. But let's try to see if we can unpack a little bit of, and I come again as a person from Caribbean background, and I'm sure Dr. Zebro can appreciate a little bit of this, that nobody wants to be signaled as the crazy one in the neighborhood. The immigrant implications of mental illness are steep. In some of our countries, people are tied like dogs to poles, you know, or thrown and sedated so that they're not, you know, addressed. I mean, those are the worst case scenarios in some of these countries, that they're just ignored like animals, literally. So here we have a greater appreciation for individuals to try to be a little bit more sensitive in this country, and that is a blessing. So the question is, how do we tackle this issue of stigma? And so how do we look to destigmatize the seeking of treatment, the seeking of improving oneself? And how, as family and community members, can we support the men in our lives that may be experiencing these mental health challenges? And throw it out, I mean, I don't know, since you're kind of new, I'll kick it up to you, Mr. Alford, first.
Yeah, you know, so one of the things that I do, I like to walk the talk, or talk the walk, I guess that's the expression. I actually go to local barbershops and do some of these mental health forums. There's one particular barbershop I target in DC, and my question was similar to yours. How do we talk about and break through the stigma of mental health issues and also treatment? A lot of the Black men and women in those barbershops, what they tell me is that they need to hear more about this, that it's not just pray it away. And prayer is a good coping mechanism, let me say that, and a powerful protective factor. But until you really know what is the difference between schizophrenia and what is the difference between depression, and what do you do if you have either one, and how do you manage? Until the more of those messages are getting out at where people congregate or aggregate, and then that will help break some of the stigmatizing interventions. Well, it will break the stigma of mental health and help people to really start to normalize it and get support. They really need to hear that more from clinicians like us. They like us to come to where they are, barbershops are the incredible places of therapy. It may not be formal evidence-based practice, but boy, you can get a lot done and you can reach a lot of people and get those messages back to the people. So that's my way of trying to break the stigma of mental health and mental health discussions.
Well, we definitely should be doing studies on the effectiveness of barbershops. I mean, that's just, I could definitely co-sign on that. And just looking at how family can support, on these issues. And let's look at what are the treatments available in the community, not just for mental health illnesses like depression, et cetera, but also substance abuse.
Is that still at me? Yeah.
I'll just open it up. And somebody mentioned the fact that that folks could also start, if people feel very hopeless, that they could start giving away their property and things like that. So that was just one of the comments that was made.
Mm-hmm.
Some of the warning signs, but family and potential treatments to mental illness and substance abuse. I'll kick it off to Mr. Hughes first, if you want to tackle that.
Dr. Hughes, yes.
Sorry, Siri.
Thank you. That's okay.
My bad.
No
Dr.
problem.
Hughes.
No problem.
That was not an intentional
I know. I'm just messing with you. Excuse me, but yeah, I mean, we have, in psychiatry and medicine in general, we practice what we call evidence-based medicine, right? So, people do studies, they publish literature, we look at the data and we say, X study is better than Y study, or X treatment is better than Y treatment, therefore X treatment is the first line. So, without going through these things on a scientific level or whatnot, most of these illnesses, depression, schizophrenia, even PTSD, things that we've talked about, will have their own guideline indicated management. For depression, this is like psychotherapy plus or minus an antidepressant. Schizophrenia can be, either usually people with schizophrenia need to be on an antipsychotic medication, but also certain psychotherapeutic modalities like CBT and social skills training can help individuals fit more so within the community and optimize their interactions with other people, which can be a debilitating thing, especially for people with schizophrenia and with impaired social skills or impaired cognition. PTSD also, psychotherapy, gold standard, plus or minus antidepressants. So we have guidelines for these types of treatments, and we try to follow them. In terms of community supports, I am not personally from this area specifically. Like I said, I'm from New Jersey, New York. But one thing I see a lot working in the hospital, when we discharge people, trying to prevent them from coming back, is to have them tap into community resources. We have here in DC core service agencies that might provide social work, case management, financial management, these types of things for individuals. Also therapeutic modalities. They might plug them in with a counselor, a psychiatrist, so that that way they prevent them from going back into the hospital, prevent them from having worse outcomes, and try to decrease their morbidity and mortality. And just to touch also on, how we can support, individuals we know that might be going through things or suffering from mental illnesses. I think the biggest thing is just having empathy and trying to put yourself in their shoes and understand, this must be a tough thing for this person. How would I like to be approached if that was me? Let me approach that person that way. And like we're speaking about in immigrant populations and Black populations, populations of color, oftentimes, mental illnesses are demonized or people are seen to be less than if you have a mental illness. So if you're going to approach someone, I say do so with concern rather than judgment, rather than saying, you know, what's wrong with that guy? You know, look at him, he looks so down. Saying, you know, why is he down? I'm concerned for that individual. Let me ask him how he's doing. So, you know, trying to be non-judgmental and show concern for your fellow individual, your fellow human, your fellow man, woman, whoever it may be. I think that's a sound way to go about approaching, you know, giving support to individuals that are suffering through various mental illnesses.
Can I ask, I have a question, and we could wrap on that and maybe take a one or two questions and then take one or two questions and then we could do closing comments. We had an issue where a parent was told in a school that their child needed professional mental health assistance. And the father just, no, he doesn't. Just said, basically, no, he doesn't. He just didn't want to face the fact that his child might be special in that way. I don't know. I'll kick it off to Dr. Zebro. How do you tackle that conversation?
Thank you, Councilor. So I think the most important thing, as you know, Ken, you know, Mr. Alford mentioned, where do we, you know, just try to have an impact? Where is you know the approach? Where do we try to just handle things? So the most important thing is just where, and because the access to care is very limited, as you know, Dr. Hughes, you know, mentioned, you know, the number of, you know, mental health professional among, you know, African American or Black, you know, community is so, you know, dismal. How do we just access care? So I think we need to start, you know, with family. So that is that's the nucleus. That's the core of the just where we can have an impact. You know, education is a family. Then where is the next step? So where is the next access to the community? You know, with regard to, you know, as far as screening, as far as intervention. I think church is a good place, like, you know, the barber shop. Church is a good place. Then comes, you know, school. You raised a very important question, but school. So the school nurse, you know, they can do screening, and they can do counseling. They do a lot of, you know, good things in school. They help a lot of kids with number of, you know, issues, including anxiety and depression. They can counsel, and when they recognize that the problem is a little bit more than their scope, then they will recommend referral. Then again, referral is kind of tricky because, as we mentioned earlier, resources are limited. If you refer somebody, then when is the next appointment? So I think we'll take a step back here, then we'll think a different, you know, strategy. The primary care. So we at least have, you know, not everybody has a primary care provider, but, you know, it is better, or there is a better chance of having primary care providers than mental health professionals. So in primary care, nowadays, most primary care, you know, family medicine, you know, offices, they do screening. They do screening for depression. This test called PH Q9, just a simple, probably 2-3 minutes, screening for depression. Same thing for, anxiety, substance use. So they can do screening. They do. Particularly, nowadays they are required to do, health maintenance as health maintenance measure. They need to screen for depression, anxiety, even suicide. So part of screening depression. So most depressed people, most antidepressants are prescribed by primary care providers than by a psychiatrist, because they don't have access to a psychiatrist or a mental health professional. Most of the population in general, particularly the African American community. So for that particular question, you mentioned, well, there is this kid identified by the school nurse or school counselor to have a mental, some kind of mental health issue. Dad wouldn't, recognize that or acknowledge that there is a problem, rather be defensive. I think that speaks to the number one, the health literacy of the general population. The other thing is the immigrant population struggling with the stigmatization of accepting mental illness is an illness like any other illness, and that can be helped and can be just some extent cured, or at least can be under control. So that is a widespread problem, that parents acknowledging that their kids have a condition, a mental health condition, they're okay to recognize, for instance, it's an infection of the ear or an infection of the tonsils, but when it comes to depression, anxiety, or some other condition, it is very hard on parents to acknowledge and accept that situation and just follow on the recommendation. So,
well, I just want to say, and I'm sorry, I'm just jumping in real quick. But I do want to say that I think we need to be a little sensitive because in some cases, I think that in this case was a little different. The child might have been a little bit more hyper, but for cases where somebody was just mentioning that sometimes we were also misdiagnosing some of the Central American kids we have here in the community as depressed because they're really mellow. But that's actually also very cultural. The fact that Central Americans are really passive, are really, you know what I mean? So I think that this is why it's also so important to have the cultural competency piece be included, in that folks have found that there were a lot of doctors and therapists that were not trauma informed or not trauma trained and not culturally competent on some of these issues. And I think that this is something that's very important to make sure that we're aware of. If it's okay, can we take 2 questions before we start closing? We have, what strategies for working with crisis level bipolar people and convincing them to accept help have you seen work? Okay, so Alford is typing an answer on that. I don't know if you want to speak to it, Mr. Alford, with the group, because I'm not seeing.
Sorry, I had lost connectivity. Well, just ask that question again. I was going in and out. I'm sorry.
What strategies for working with crisis level bipolar people and convincing them to accept help have you seen work?
Well, first of all, what I've seen work is having that trusting relationship. The person who has the best level of trust and communication can help them discover that they may have something that needs to be addressed. And really working through that relationship they might have with that person. It could be a family member, a relative, a pastor, any person that has that trust, but then making sure that that trust isn't about enabling them not to get help, but helping them to understand that we need support. If that's established, Prince George's County, we have a crisis team. It's called Affiliated Asante. They can help guide the person to what to do next. You got someone here who's demonstrating behaviors that does not allow them to work, to go to school, to have a job, to be productive, and they are disintegrating. What can we do to support them next? That crisis center affiliated Asante can tell them everything from crisis management in the home and managing that situation, or does it need a higher level intervention? Meaning, does it need to be going to maybe a hospital, a therapist, or someone else? So I would suggest that pressing on the person they know, using the crisis center here or crisis centers across different locations, and then from there migrating to what needs to happen in terms of managing and supporting a person with that bipolar type diagnosis.
So we also have 211 that is available here in the county, and we have community crisis services that are also available, and we have National Association for Mental Illness, NAMI. They have support groups throughout the county, and I know for a fact that they have one in the northern part of the county, and I know they have some Central Park, and this was Elliott Reed. So I know that they have some in the central and southern part of the county as well. Jonathan Goody raised a question that I think we had already addressed, but we can reiterate some of these issues. Can the panel talk about the effects of racial trauma and how it impacts on the mental health of men of color? There's so much racism, social injustice, police brutality, discrimination, microaggressions, etc. And I think Dr. Hughes said it very succinctly. I don't know if you want to just reiterate a little bit about.
Yeah, so I mean, in general, the data will show that Black people in general have higher rates of psychological distress than our white counterparts, irrespective of whether or not the prevalence of depressive disorders are or PTSD at that. The fact that the prevalence of those is about the same across the board, we do experience higher levels of that distress. There's one important point that I want to make that is known to me, perhaps not to the rest of you guys, maybe Dr. Zebro. The diagnostic criteria for PTSD has an exclusion criteria that says if the traumatic event that, like Dr. Zebro was mentioning, you have to experience an extreme traumatic event or repetitively be experienced or exposed to a traumatic event. If that event is experienced through electronics, like a phone or YouTube or something like that, it by the DSM criteria does not meet criteria for PTSD. And that is something that a wave of people of color within the APA, within the field of psychiatry, have been trying to petition the board of the DSM, the people that edit that, to try to change that. Because as we know, over the past decade or so, everyone has a cell phone, everyone sees these shootings 1 minute after they happen. Everyone continuously sees them on the news, and that all goes right to your phone, which you have on you and you see most of the time or multiple times throughout the day. So that undoubtedly has a psychological effect on Black people or people that are similar to the individuals that are in these videos. So I'm hoping that exclusion criteria is removed, and we might see an increased prevalence of the diagnosis of PTSD within the Black community. I think it's being masked by that exclusion criteria, and people are then getting diagnosed with schizophrenia, misdiagnosed with schizophrenia, or misdiagnosed with something else, maybe a paranoid delusion disorder or something, rather than PTSD, and that misdiagnosis will preclude these people from receiving the appropriate treatment for their diagnosis. So That's something that, I have been, keeping my ear on. Dr. Hairston, the program director at Howard University Hospital, I believe she's on one of these boards in terms of editing DSM, and she's been pushing for that along, like I said, with a number of other Black psychiatrists to try to get, a greater scope for that diagnosis, because like you said, seeing all of these things, police brutality and whatnot, is certainly affecting Black people negatively, and more so than our white counterparts, certainly.
Thank you. And I also want to mention that you said that African American male are 50% less likely than others to get help, and 1/3 less likely to be diagnosed. But when they do have an issue, they're more likely to have a prolonged issue of mental health problems.
Yes, the severity of the episode, as long as how long the episode lasts and how debilitating it is, it's all increased for Black individuals, and it's about a 50% utilization disparity. So 50% less Black people will reach out for resources or services to address their mental health versus our white counterparts. Yeah.
Exactly. And the fact is that there is a scarcity of individuals in the community that are able to service us in a culturally sensitive way. I think that that's also, you mentioned that there was only 2% of all social workers are you said Black male social workers, or
Black male, woman, non-binary, whatever, and 2% for psychologists, psychiatrists that identify as Black, and about 4% of social workers who identify as Black across genders. So then, so the problem arises if you are a woman of color and you want to see a woman of color provider, that number would then be even smaller than that. Or a man of color provider would be even smaller than that. And that's presented problems for myself, even, looking for, when I moved to DC, looking for a new therapist, trying to find a Black man to treat me. It was extremely difficult. It took me about 6
years. You may have to look in the mirror.
Can I jump on that one too?
Yeah.
That statement. We at Prince George's Hospital, University of Maryland, we do have a PHP IOP. We are fortunate to have African American providers, both our social workers, our therapists. We have a Black music therapist, which is quite rare to find, but we've been blessed to have that person. And we know the value of that because a lot of our patients will come to people that they can feel comfortable to open up to, knowing that they share that that racial that African American experience. So we appreciate having that both at our Laurel campus and our Prince George's campus. If people are listening, we do offer that, and people can get that service from those providers that are African American.
Wonderful. I just want to highlight one of the postings that was done by one of the board members at CCSI, the Community Crisis Center services, suicide, domestic violence, mental health resources. And I think they also have, they also manage the Trevor hotline as well as our Warm Nights for the Homeless. Is Community Crisis Services, Inc. 301-864-7095, and that's www.communitycrisis.org. And we do have a 24-hour hotline, 1-800-TALK-8255. And this is from CC Melvin Scott. And so can you, CC, can you double check that number, honey? I'd appreciate that because it looks like there's too many digits. Also, on that note, I want to say thank you to everyone for coming on this panel. We are at 2 minutes to the deadline, but I want to just give an opportunity, 30-second wrap up for everybody to say some closing remarks, and we'll send off everybody to their next Memorial Day cookout. So Councilmember Wiley, Charles Wiley, do you want to kick us off?
Thank you for having me today. This has been amazing, but I just want to encourage people to invite your friends and family to the cookout. What that means is, like, we like to break bread, and that's the time where we have our deep conversations. That's where I found out that I needed to see somebody. I didn't know anybody in my family saw people until we started talking about it at the cookout. So, you know, start having those conversations with your friends and family, and yes, we got to do it safely now, but start inviting people to the cookout and let's have these conversations. Let's start fixing these problems at home so we can be able to utilize the resources that we're creating right now. So thank you so much for having me. It's been a pleasure with all of you all. I'm so honored.
No, it's been a pleasure to have you. Mr. Alford?
Yes, I want to say this is a very good conversation, but this is where it starts. There is hope. Despite the darkness, despite all that we've mentioned, I mean, we are facing a myriad of social issues. There is hope. There are people there who, like myself and other people in this panel, are committed to helping people find that. So thank you for giving us the opportunity. We are guardians of this thing we do, and we want to help, we want to serve. And particularly my role, I'm a nurse, psychiatric nurse, but I'm also an executive, but I also am a person experiencing social things like everyone else. And if I can connect to someone and help them find their way, I'll do that. I left my information in the Q&A, and if you need additional support, please let me know, and thank you.
No, thank you so much. And I have to say something to remember, that when taking care of others, you got to also remember to take care of yourself, because if you don't, we're all screwed. So, Dr. Zebro, do you want to say some closing remarks?
Thank you very much, everybody. It is a very good opportunity to, exchange views, and, recognizing mental health is a huge, community problem. Starting a conversation from there, we just, can go to some kind of solution step by step. So thank you, everybody, for this opportunity.
Thank you, Dr. Zebro. Thank you so much. And Dr. Hughes, I'm going to have to ask you where you're from in Jersey and New York, in New York. As a New Yorker myself.
I'm originally from Pleasantville, New Jersey, South Jersey, right outside Atlantic City.
Okay.
Yes.
I lived in Perth Amboy for a little while, and in some.
Okay. Perth Amboy, yeah. I went to Rutgers for undergrad, so that's.
Yeah, so New Brunswick.
Yeah, kind of that area. And then my medical school was in Newark, so I kept moving north.
Where did you stay at Rutgers?
Pardon?
I was on Bush when I went to Rutgers.
Oh, nice. Oh, nice. Yeah, I lived on Bush freshman year, and then I moved off campus to College Ave. Awesome.
So you're in good company.
Mm-hmm.
And in New York, did you do a little bit of time in New York or no?
Yes. I spent some time in Brooklyn and Crown Heights, which was
awesome. Oh, you're talking my heart right there. Some good Jamaican baddies. Oh, yes. You know, and I'm sure you probably had a good old time at the Caribbean Festival for Labor Day.
Yes, indeed.
It's on. It's on.
Right on Eastern Parkway. Yeah. Mm-hmm.
It's on. It's a party. So with that, closing remarks.
Yeah. So again, thank you guys for having me. I think again we need to just highlight the need for everyone to be more vulnerable, for everyone to be more open, and it really starts with the individual. So just something as simple as telling your friends that you love them, telling your guy friends, hey man, I appreciate you, every day. It could start softening them up to understanding that these are normal things. It's not something that you need to be ashamed of to tell your friend that you love them, or to check on them or ask them how they're feeling, or for them to open up and be vulnerable. So I think it starts with the individual. Obviously, we need to go, broadly and talk about these things, like Mr. Ken said, in the barbershops, in other forums, but it really starts with the individual. So, I encourage everyone to just try to find themselves and try to be more vulnerable, be more open, and ask more questions of their fellow men or women.
And thank you for that. And I just want to say, I thought that this was going to be the hardest session to get people to. It turned out to be the best session to have people at. So with that, I want to say thank you, gentlemen, for being with us today. It's been an honor and a pleasure. And I do think that this is just the beginning of this conversation. This, as Mr. Alford said, we've got to do this more. And I definitely want to talk, bring you back for a better chance to see you shine. With that, I want to say thank you to Alvy Escobar from my staff, who's been the guiding light behind the scenes on the technological front, and Ms. Jobina Brown for making sure that everything is working properly in terms of making sure everybody's here, and Ms. Miriam Lev for translating everything to make sure that this is something that is accessible to all in our community. And so we want to say thank you all, and have an amazing Memorial Day weekend, and see you at the cookout. All right, y'all.